the left ventricle has completely encroached and it is almost touching the posterior, the vertebral column, anterior surface. Now you can be sure that left ventricle is enlarged. So these are the 3 points when you have in your mind, you will never get confused whether there is left ventricular enlargement or right ventricular enlargement. I hope this point is very clear to you and very important to you. Okay. Coming to the right ventricle, you can see here the cardiac apex is elevated. This is the cardiac space. This is not the normal apex of the heart. It is elevated by the enlarged right ventricle. You remember on the last session I have told the right ventricle is sitting on the diaphragm. So when it is enlarging and laterally, it lifts up the apex. So this is an indication the right ventricle is enlarged. Another important point is again in the lateral view. Just now I was telling you retrosternal space. I was telling you about the retrocardiac space for left ventricle. Here I am going to tell you the retrosternal space for the right ventricle. So when the right ventricle is enlarged, as you see here, it obliterates gradually this retrosternal space. That is an indication of right ventricular enlargement. So these 2 points you must remember to say in the examination as well as to practice in your day-to-day practice. Okay. And the rest of the things here, you know about the mitral stenosis that day I was clearly telling you. So I have sent the combination of the previous lecture and the current lecture to you. So you can go through that. And I will be highlighting only the important points in this second session, which are not covered in the first session. Okay. Yes. Here you are. Regarding the pulmonary arteries, you know, pulmonary arteries, pulmonary veins. Pulmonary arteries only make a big shadow in the hilum. So most of this shadow in the hilum is due to the pulmonary artery. So you know pretty well it starts by the main pulmonary trunk from the right ventricle, and then it divides into 2, that is the right pulmonary artery and the left pulmonary artery. How to say pulmonary artery is enlarged? This is a big problem for doctors as well as the medical students. Please listen to me, it's easy. When you draw a tangential line connecting the aortic nerve and the left ventricle, the space between the line and the cardiac border at the hilum, at the hilar level, should be below 13, maximum 15 millimeter. So if it goes above that, it is indicative of prominent pulmonary arteries or enlarged pulmonary arteries. So this will be an evidence to prove that the pulmonary artery is enlarged. So again I repeat, the distance between the tangential line connecting the aortic nerve and the left ventricle and the left cardiac border at the level of the hilum should be below 13 millimeter, maximum 15 millimeter due to the error and other things. But if it is above that, for example here it is 17 millimeter. So naturally you see the left pulmonary artery is prominent and enlarged. Okay, another example. eye. You see here, both pulmonary trunk are very much enlarged. Here again, you are proving by connecting whatever be the size of the heart. You just make a line connecting this. Now, the pulmonary artery is beyond this, protruding out, and the distance naturally is increased at the hilar level. So this is how you prove that pulmonary artery enlarged. The commonest condition that you should never miss is pulmonary hypertension. So pulmonary hypertension, as you know, can occur through valvular deformities, or it can also be idiopathic. So idiopathic pulmonary hypertension may not be associated with any murmur. So it just by the compliance, and it occurs mostly in younger female. So about age of 18, 20, 21, they come with dyspnea. When you try to auscultate, there is no murmur at all. So patient is giving specific complaint that she is not able to do any sports in the college. She is not to do any hard work. So immediately you take an X-ray, you see the pulmonary arterial hypertension. So now you know how to diagnose a pulmonary arterial hypertension. Then another important point connected with this cardiac failure. Last session we were discussing about the two types of cardiac failure. You must remember always, whenever they mention congestive cardiac failure in the word, they mean to say right ventricular failure. It is a chronic affair. I told you, explained you yesterday. Patient may be on drugs for many months, many years, and may continue the longevity. But left ventricular failure is an acute emergency fatal condition. Unless you make a timely diagnosis and proper treatment at the time, you may not save the patient. Before you get a response from a duty supervisor, the patient may die. So as a houseman or as a junior doctor, you must be able to diagnose this acute left ventricular failure. The commonest presentation in acute left ventricular failure is pulmonary edema. So for the undergraduate, for examination purpose, you keep this picture in your mind. So this is called bat's wing appearance or butterfly wing appearance. So on both sides you are able to see wing-like spread of the opacity due to congested, enlarged pulmonary vessels, and subsequently alveolar filling and perihilar, peribronchovascular cuffing. All these three things constitute to make the butterfly wing appearance or bat's wing appearance. I repeat because this is important for you. This is a life-saving technique to make a diagnosis. So whenever the patient complains of acute dyspnea, even in myocardial infarction, patient was being treated in the ward, in ICU or anywhere, and suddenly he develops acute dyspnea, you must rule out pulmonary edema because one of the cardiac tendinae might have ruptured. Papillary muscles may be disintegrated due to the infarction. So you must be careful to make a diagnosis. The classical appearance will be bat wing appearance. The left ventricle may or may not be enlarged. If the patient is already hypertensive, you can get associated left ventricular enlargement. In myocardial infarction, I want to caution you again, there may be associated pleural effusion. In this case, when you aspirate, you may not get effusion fluid, typical exudate, but you will get neither transudate. Instead, you will get hemorrhagic fluid. So in myocardial infarction, suddenly when the patient complains of pain, especially like pleuritic type of pain, and when you take an X-ray, if there is evidence of accumulation of fluid, immediately you diagnose hemothorax. It is not pneumothorax. Remember, it is hemothorax. Don't call in that situation, it's a pleural effusion. Okay? Right. So again here, as far as the cardiovascular system is concerned, you must be very, very alert in making the correct diagnosis. Patient may be just anemic, and patient may come to you for dyspnea. In that case, he may not have anything else except anemia. So even the X-ray test may be normal. There may not be any cardiac enlargement, cardiomegaly or pulmonary edema, but patient may have dyspnea. So in that case, you can confidently treat him only for anemia. Definitely he will improve. Sometimes he may need hemotransfusion, or he may need just pills, iron pills. But you must rule out always the coexisting worm infestation. That is very important. Most of the times, practicing doctors ignore that, because those days we used to do motion examination, stool examination. But nowadays I rarely see doctors prescribing that or laboratory doing it. Perhaps they think that it's a nuisance. They don't handle that. But it's very important test to see the live organisms. You can see hookworms, you can see the Ascariasis, you can see the eggs in the tube. Confidently, then you can treat the patient. Because these are some of the important causes of anemia. With the worms in the body, whatever load of iron you are going to give, the patient may not give satisfactory improvement, because the cause is not removed. It is already there. And again, in anemia, patient may come with typical failure. There may not be any cardiac lesion. There may not be any valvular lesion. There might not have been any cardiac attack, any myocardial infarction. But patient will develop pedal edema, ascites, all these things typical of cardiac failure. So you must work out to rule out, to find the exact diagnosis. So when you ignore some important points, you may miss the diagnosis. So until now, is there any doubt you want to ask me? Any doubts here?
No, doctor, none.
Okay. Now, look at this picture. I want to highlight a few more, because you might have seen some of the important radiology report, which you may not understand, or you are not able to correlate, or you are not able to fix what this means. They might have written peribronchial cuffing. So I will show you that finding so that you can remember. You see here, the bronchial, when it is patent, it will be filled with air. You can see the bronchial. Yes. That is called air bronchogram, isn't it? Right. When you see this bronchial, immediately you turn your attention to either side of this bronchus. The wall will be thickened. You see here? You see what you call colloquially white. Okay? This opacity, parallel opacity, parallel to the bronchial tree. This is called peribronchial cuffing, thickened. Most of the times when you see in this failure, it is due to the accumulation of fluid in the peribronchial tissue. When it occurs in inflammatory lesions, it may be due to fluid as well as inflammatory cells. So when it spreads to the interstitial area, that is in between the alveoli, alveolar walls also will be thickened, and also when it spreads to the lymphatics, draining lymphatics. So collectively all this will lead to curly lines which I showed you yesterday. When the fluid, the next stage is the fluid will be going out of the blood vessels to the interstitium. Then the next stage it will enter into the alveoli. So when the alveoli are filled up, you will get consolidation like appearance, and if they are more pronounced in the hilar region, you will get butterfly appearance. Now you understand the pathogenesis of interstitial edema and butterfly appearance, curly lines. This is how it is shown on the X-ray. All these cases may be associated with effusion into the pleural cavity, effusion into the pericardial cavity, apart from your pedal edema and ascites. But in this case, you will neither get pleural effusion nor hemothorax. Instead, you will get serous fluid collection. So it will not be pus-like, it will not be blood-like. When we aspirate and send it for histopathological examination, they will say no inflammatory cells. It's not an exudate. No high protein. So it indicates it's not inflammatory. So you call this condition as hydrothorax. But a common term, pleural effusion, they mean the pleural effusion. In all these cases, whenever there is cardiac failure, you will get definitely, especially in right-sided cardiac failure, prominence of superior vena cava and prominence of the liver. So liver congestion is quite common. So liver may be palpable. So in cardiac failure, right-sided cardiac failure, the liver may be even tender. So don't get diverted because of the tender enlarged liver. It can occur in cardiac failure. So what happens in cardiac failure, because of the collection of fluid in the peritoneal cavity, you will get ascites, and this ascites pushes both the diaphragms equally, and so you may get both diaphragms at the same level as you see here. No more the right in upper level and left at the lower level. So these are all some other important points I want to highlight. Any doubt? Okay, we will go to the next lecture. Are you able to see the screen?
Yes, Prof. Yes.
Okay. Okay. Hepatosplenomegaly is an important topic for undergraduates. So when there is a case, definitely they will keep it for your professional examination. So you must know some of the important radiology details of the spleen, and we will correlate some clinical features with the splenic pathology. Okay, so the main learning outcomes here is how to identify splenic enlargement and how to appreciate the various findings in splenomegaly and correlate with the clinical features to reach a diagnosis. So how will it appear in traumatic cases, inflammatory cases, and when there is a mass? Sometimes the blood supply may be compensated and the patient may come with similar findings of left hypochondric pain, an enlarged spleen, everything, but it happens to be infarction. So all these things today we are going to see. Along with that, finally, we will be touching some points about the lymph node, how to identify, recognize the lymph nodes, enlarged lymph nodes, and abnormal lymph nodes. Both are different. Enlarged lymph node is different. It may not be abnormal. So I will explain to you later on. Okay, so you know pretty well, it is something like a closed fist size. Spleen is closed, you close your fist, that is the size of the spleen in normal subjects. This is placed within the thoracic cage and so called with good protection. So spleen is not easily injured. At least in the liver and the right hypochondrium, part of the liver is below the subcostal margin, especially in young children. It is palpable, so easy to get injured. But spleen is always within the thoracic cage. It gets its supply from the splenic artery, which is a branch of celiac axis. So it runs transversely, the splenic artery runs transversely across the stomach to reach the hilum. The hilum is as a depression in the spleen, and on palpation in an enlarged spleen, the spleen is characteristic by a notch near the inferior pole. Don't confuse this notch with the hilum of the spleen. So when you palpate a mass clinically, two things are important: whether it is superficial or deep, that is important. If it is not easily palpable, bimanual palpation is required during your clinical examination. It is usually not spleen. And if it is associated with left intercostal spaces pain, it is usually spleen. If it is associated with renal angle tenderness and bimanually palpable, it is usually renal mass. So this is how you must distinguish clinically. So 90% of the patients will not have spleen palpable. Even in children also, it is not easily palpable. 1 minute, I will correct it. Yeah. Okay. Okay, when this Zoom is out, I have already sent another link. Kuhan? So, students, you got the another link?
Doctor, I'm sending it to them in a bit.
Okay. Open it.
Okay.
Usually it is for 45 minutes, but why? Yeah. You are able to hear me, isn't it? Now.
Yes.
I can still continue. Okay.
Yeah.
If it is completely off, then you can switch over to the next link. Okay. So
yes, okay, Doctor. Yes.
Yeah. So you can see that the pancreas extend up to the spleen. The hilum of the spleen will be sometimes seen with the tail of the pancreas. So it is quite normal. So don't worry about it. Okay. So you pretty well know that it is, whenever it is palpable, you should think of splenomegaly. So this is the not what I meant. So splenomegaly can occur if you enumerate the causes of the splenomegaly. I think it will work out to be at least 60-70 causes. So don't worry about this. If you are able to say at least 5 causes to the examiner, he will be happy. So think of common causes like typhoid. You can think of very common causes like malaria, portal hypertension, anemia, especially in young children, whenever there is pernicious anemia or hemolytic anemia. So like this, you must think of easily recollectable causes and you must tell. So don't blink for a very long time and the examiner will get upset because you do not know some common causes of splenomegaly. Lymphoma, leukemia, you cannot forget. So these are all causes of enlargement of the spleen. Only thing is, sometimes you may not be able to say whether it is mild, moderate, or huge, because you have to measure it to say whether it is mild, moderate, or huge. On plain X-ray, when you see the fundal gas shadow not below the left dome of the diaphragm, it is pushed medially and there is a soft tissue mass as you see here, then you will say it is spleen. Another soft tissue finding is, you look at this arrow, the splenic flexure of the colon is pushed down. So now these two findings are very important on plain X-ray. As far as the ultrasound is concerned, it's an easy way to confirm splenomegaly. Just put the probe in the left hypochondrium. Dr. Tint will demonstrate you during his CSS how to look for perisplenic space. how to look for Morrison's pouch. So you carefully see that and you practice, because it's a hands-on session. You practice, then it will be easy to practice in your clinic. So just learn it now and then you can practice later in your clinic. Okay. So here you can see pretty well the whole of the spleen, upper pole, lower pole, and the body of the spleen. And you can see the notch also, and you can see the hilar area. It is homogeneous medium echoes. Homogeneous medium echoes. So when you try to measure from the upper pole to the tip of the lower pole, maximum normal is 12 centimeter. 12 centimeter. This is normal. But usually patients will have 8 to 9 centimeter of spleen only. So we give a maximum, add 3 centimeters, we give maximum 12 centimeter. So here in CT you can see clearly the splenic enlargement, whereas the liver is normal. Only when liver is also enlarged, you say hepatosplenomegaly. Now compare this with this. Here you see spleen is enlarged, yes. At the same time, look at the liver. Here liver is normal, medium, homogeneous, medium density. But here it is looser, less density. You see, gross difference. You compare the liver with this liver. So here you must think of fatty infiltration of the liver, which may be due to alcoholic cirrhosis. So later on, even non-alcoholic fatty infiltration can lead to the liver failure. So don't treat fatty infiltration simple. Instruct the patient to follow your advice, take care of his nutritional habits and correct these earlier. Otherwise, it may go for even portal hypertension. Okay, so you can measure like this longitudinal measurement and this transverse measurement. Okay, we will look at some congenital anomalies. So when you do the ultrasonography, you will find similar echogenicity and nodular areas. So only two possibilities you must think of. One is lymph node enlargement. Another is accessory spleens. So you can get accessory spleens like this. That is a congenital anomaly. Sometimes what happens, this main spleen is absent totally. Only accessory spleens will be there, but multiple in count. So any mass in the splenic area below 5 centimeter, you must think of accessory spleen, especially, below 5 millimeter, especially when it is of the same echogenicity. Most of the times, accessory spleens will be crowded around the hilar area. You see here, this is an example of splenenculi. Splenenculi, that is multiple congenital ill-developed spleens. So small multiple areas, no big spleen seen here. You see here CT scan, splenic area is occupied by the multiple splenenculi. Other name for this is polysplenism. So multiple splenic tissues. Now to compensate that space left by the absence of the spleen, the left lobe of the liver overshoots. So you can see the left lobe of the liver encroaching the splenic area. Another congenital anomaly is absence of spleen. Whether a man can live with asplenia. Hello? Are you able to hear me?
Yes, okay.
Yes, Prof.
Yes, yes.
So, in one particular clinical condition, there will be total absence of the spleen, and that area will be occupied by the left lobe of the liver, as you see here. This is asplenia. It is called Eve-Mark syndrome. Eve-Mark syndrome or Eve-Mark syndrome. You can see the spelling there. Okay. Sometimes it occurs in MCQs. So you remember that it is the asplenia with the absence of spleen and enlarged left lobe of the liver encroaching the splenic space. If it occurs in the early childhood, patient may die. Because in the early childhood, especially in neonates, spleen is very, very important, along with bone marrow. Bone marrow takes its role a little bit later. The spleen is a hemopoietic organ. And not only hemopoietic, it is also in charge of very good active lymphocytes. And it is also removing the worn-out cells, which are harmful if they stay back and circulate in the body. So these are the three major functions of spleen, which are absent in neonate. So most of the times they die of infection. Okay. Some interesting congenital anomalies is, like any other organ, spleen also has some attachments. Don't think spleen is floating. It is in the left hypochondrium. How does it stay there? Very important. If you recollect your anatomy, spleen is anchored by several ligament-like structures. Splenorenal inferiorly, splenodiaphragmatic superiorly, gastrosplenic medially, splenocholic inferior-medial. All these ligaments, they attach to the spleen and they keep it in position. Now, in some individuals, the mesosplenium may be very relaxed and very big, hanging. So you may see spleen one day You may not see the spleen in that spot another day. So when you take the probe somewhere else in the abdomen, you can find the spleen there. This is called wandering spleen. Wandering spleen. Nothing wrong until it goes for torsion. So when it goes for torsion, it is a surgical emergency. So immediately you have to identify. There is one more interesting congenital anomaly. The splenic tissue will be found in the left testis. It is surprising. This is called splenogonadal fusion. During development, you all know testes are not developed in the scrotum. They are developed in the lumbar region. Nearby, the splenic tissue gets migrated to this testicular tissue, and it will be descending down along with the testis into the scrotum. So this is the pathogenesis of this splenogonadal fusion. This will not occur on the right side. Up. So when the spleen function, just now I enumerated some of the functions, when the splenic function is very high, active, we call it as hypersplenism, which is also not good for the patient because it will start killing even normal RBCs, normal W white blood cells. So you have to be careful to recognize hypersplenism. Not all splenomegaly are hypersplenism. Don't confuse the two terms. Splenomegaly is different from hypersplenism. So you have to look for whether this splenomegaly is hypersplenic, exhibit hypersplenism. When the splenic tissue is absent, the function also reduced, so we call hyposplenism. Hyposplenism occurs in hypoplasia of the spleen, aplasia of the spleen, surgical procedure like splenectomy and done, or due to some disease, it is atrophied. All these are causes of hyposplenism. And just now I was telling you, showing you the picture, the pancreas is extending up to the spleen. So any inflammation in the gallbladder, pancreas can also cause spleenitis, and it may depress the function, causing hyposplenism. Sometimes malignant cells. Usually malignancy of the spleen is rare. When it occurs, it can depress its function, causing hyposplenism. Okay. Now we will come to another important area, splenic trauma. So by this time, you might have known there are several grades, several classifications. All these are theoretical. You can remember for the exam purpose. But radiologically, you can say whether it is superficial trauma, like small tent, or small laceration, subcapsular laceration, or pericapsular collection. So this all can occur due to trauma. Trauma can be causing minimal injury to the spleen, or sometimes maximal injury to the parenchyma. So the easiest way to diagnose is first apply ultrasonography, then go for CT scan. So when there is injury to the splenic vessels running across the capsule, hematoma can occur pericapsular area, in the pericapsular area, as well as in the subcapsular area. When it occurs in the pericapsular area, it can spread all along the spleen. When it is occurring in the subcapsular area, it can compress the splenic parenchyma and cause distress. The hyposplenism also can occur. When you do the ultrasonography, you see the different texture, echo texture. This is normal splenic texture, but at the same time looking like an enlarged spleen with different echo texture in the inferior part. This has been due to rib injury causing injury to the splenic pulp, causing hematoma, which is perisplenic hematoma. Here it is called perisplenic hematoma. Here hemorrhage does not occur within the parenchyma but outside. So it is called perisplenic. Perisplenic can be two. One is subcapsular or pericapsular. When it involves the parenchyma, you can see as a small tent surfacing from the outer lateral margin, just a few centimeters. When it occurs deep, medium type of injury. Sometimes it can extend the whole of the spleen, may feel the trauma, the impact of the trauma. It may be shattered into many pieces, and the blood accumulation can occur in this perisplenic area, in the hilar area, within the parenchyma like this. So this is otherwise called ruptured spleen, shattered spleen. Most of the times in trauma, the surgeons won't like to remove the spleen because the spleen is harmless within the body even if it is ruptured, unless and otherwise there is associated torsion or associated involvement of the vascular pedicle. Just a hemorrhage into the parenchyma does not necessitate a surgical procedure, surgical removal, whereas involvement of the vascular pedicle as such or torsion, definitely it invites the surgeon to do his job. Here you can see zebra-like appearance. If there is no history of trauma, don't take this as laceration or ruptured spleen, because this is quite common in CT scan, especially after contrast. So when there is enhancement, CT enhanced, contrast enhanced CT given to you, and if the patient does not give any history of trauma, no pain in the left hypochondrium, then you think of the normal appearance. You see, just simple. You see further sections of the CT scan, the spleen returns to normal. So this is due to the rich blood supply and differential blood supply. It gives an appearance of zebra spleen. You can see here in the CT scan, we have seen the perisplenic collection in ultrasound. Now here in the CT scan, you can see perisplenic collection. So all around the spleen, you can see. Sometimes similar appearance can occur, but with associated fever and rigor. So when there is fever and rigor and tenderness in the left hypochondric area, without history of trauma, you must think of splenic abscess. It can occur in immunocompromised patients, in portal hypertension, in septic thrombosis, septic emboli, leukemia, lymphoma. So in all these cases, splenic abscess can occur. So it will give an appearance on the ultrasound like this. So the affected area will show low echogenic texture, low echoes. They may be sometimes multiple, or one huge abscess like this with irregular shaggy margins. You can see here. So there may be sometimes single abscess with multiple septae. The septae will be like this. You can see the septae coursing along inside, within, you can see. Sometimes thickening of the septae will appear just like an intracavitary mass. Sometimes when you do the ultrasonography, you see multiple echogenic foci like this, dot-like, button-like, echogenic foci. Here also, whenever you see this appearance, you will think of a single condition, whether the patient had tuberculosis earlier. You must rule out, because tuberculosis is the commonest condition which can give multiple echogenic foci like this. These are all due to calcifications on the granulomatous tissue which occurs in tuberculosis. So tuberculous granulomatous tissues can. And sometimes the Doppler echoes are important in the analysis of spleen, especially when there is associated ascites, splenomegaly. You must rule out portal hypertension. So you will be able to see multiple worm-like translucent areas on ultrasonography, especially in the hilar area. So medial aspect of the spleen will show multiple tubular structures, worm-like structures. When you change to Doppler, you will see blood flow, active blood flow, energetic blood flow within these tubular vessels. So you made a diagnosis of splenic varices, which is very, very common in portal hypertension. The other common cause is splenic vein thrombosis, pancreatitis. So these are all some of the other causes that we must remember. Congenital varices is quite rare. Then we will talk about something on masses in the liver. So whenever you see a good description of complete anechoic area, whenever you see complete dark area, you call it as anechoic, A-N-E-C-H-O-I-C, anechoic. There is no echoes, completely dark. When you see like that with clear margins, and posteriorly if there is enhancement of the echoes, all the three features are there, it is a cyst. I would say in any area, in the kidney, in the liver, if all the three are satisfied, you first think of cyst. It can be a simple cyst, it can be a senile degenerative cyst, whatever it be. Primary cysts are congenital in origin. These are otherwise called epidermoid cysts. Mostly they are small. Secondary cysts are in majority of the conditions due to secondary cyst, which may be due to many causes. That day I was telling you that maybe you will get the cyst in infections, mere infections. So mere infections can cause cyst. For example, Hydatid cyst. So pancreatitis, which may lead to pancreatic cyst as well as pseudopancreatic cyst. So these are all the some of the causes. But anywhere when the cyst is below 5 centimeter, the surgeon may prefer to leave it as such unless it is very symptomatic and causing problems like hemorrhage within the cyst, pain, frequent pain like this. Otherwise, don't touch it. So if it is above 5 centimeter, the chances of rupture is there, so better we inoculate the cyst. One typical example I can show here is beautiful epidermoid cyst, that is a primary cyst. You can see here how nicely it looks like pearls of different colors, shining, you see. And when you do the ultrasound, it is not simple cyst, because just now we have seen simple cyst that is clearly anechoic, but here you see enormous echoes completely filling the whole cyst. Even though the cyst wall is thin, only occasionally thick in certain areas, but majority of the area the walls are thin, but it is completely filled with echoes. So this is typical of unilocular epidermoid cyst. Majority of the epidermoid cysts are unilocular, that is solitary and unilocular. Sometimes rarely you can see calcifications. So whenever there is pancreatitis, it is not a surprising fact that there may be pseudocyst even after recovery of the pancreatitis. In such cases, you don't fail to look at hilar area of the spleen. You see here typically a cyst in the hilar area of the spleen. This patient had pancreatitis earlier, and the cyst will be grayish in appearance, and if it breaks down, there may be chocolate colored fluid coming out, thick fluid, and very dangerous. You should see that it is not breaking out. Very important. And another beautiful cyst you see here, very nice, no? You like to play with this. These are all hydatid cysts. Those people who rear the dog as a pet animal must keep vigilance. You should not allow it to stay around, number one. Number two, you must give proper vaccinations, and you must follow hygienic methods of not allowing the dog to lick your face, especially when there is a crack in your skin or a cut in your skin. Don't allow the dog to come too near. Dog is the primary host in hydatid. So dog is actually, I give you a warning, it causes two trouble problems. Sometimes fatal, sometimes not, sometimes mostly fatal. Number one is rabies. Number two is hydatid. Hydatid is the one you might have read about hydatid in your earlier phase. Echinococcus granulosa. Very small parasite, very small. But it can migrate up to the brain. So you can get similar cysts throughout your body, liver, lungs, abdominal cavity, brain. So anywhere it can cause. How to identify them radiologically? So on the plain X-ray, you will not see the hydatid cyst as such, but there will be organomegaly. If the hydatid cysts are in liver, hepatomegaly. If it is in the spleen, splenomegaly. Like that. When you do ultrasonography in such cases, you will see typical cyst. Here, I want to show you there are multiple cysts within You see here, within the big cyst, there are multiple cysts. These are all called daughter cysts. You might have studied about the Echinococcus granulosa. So this daughter cyst may be numerous in number. You think that it is only one cyst, but when it is open, you can see 50 or over cysts inside. Because the hydratid has a capsule which broods many daughters. Then after growing, the daughter cyst will get detached from the wall and they will be free to move within the cystic cavity. So when you treat the hydratid cyst, if at all you treat with surgery, you must be very careful not to rupture the cyst. If you rupture during the removal, say for example there is a huge cyst in the liver, you prefer to take it out, okay, unless you are very much trained to remove, to enucleate it intact. If it ruptures or if it starts leaking, then patient will have hydatidosis. Multiple cysts will be developed in the peritoneal cavity. Imagine, multiple, maybe hundreds. So whenever you feel a mass, if it is cystic on palpation, okay, you must rule out abscess and cyst. Another one is hemangioma, a benign tumor, can occur in spleen, which may be soft. But if it is solid, you must rule out malignant tumors. Of course, just now I was telling you, lymphoma, leukemia are also malignancy. Secondary deposits are not very common in spleen. So you must think of, if you rule out lymphoma, leukemia, you must try to rule out primary tumor. So ordinary benign tumors will be hemangiomas, lymphangiomas, hamartomas. As far as the metastatic diseases are concerned, you must think of a few conditions. One is, we already told, leukemia, lymphoma. The other is melanoma. Melanoma can spread to the spleen. And of course, carcinoma of the breast, ovary, bronchogenic carcinoma, colonic carcinoma can also spread to the spleen. On ultrasonography, it may be small and a solid tumor. Whenever you see similar appearance, like liver hemangioma, first you think of hemangioma. So when you do the CT, when you inject contrast, it will exhibit typical phenomena. It is enhanced, then drain out, and again may re-enhance. And most of the times it gives a button-like appearance. So these are some of the characteristics of hemangioma. As far as the malignant tumors are concerned, first you must think of Hodgkin, lymphoma, leukemia. Okay. Hairy cell leukemia is one of the types. Here, even though it sounds a little bit scary, hairy cell leukemia, but most of the times it is survival rate is good when compared to the other malignant tumors. So most of the times, if they are benign tumor, if it is harmful, like repeated pain, repeated hemorrhage within the, they will remove. Otherwise, they may not touch. In primary malignancy, you will get variety of varied appearance. You can get solid tumors, you can get cystic appearance and solid component within that, cystic component and solid component within that. You can see multiple deposits. So whenever there is splenomegaly and it gives multiple deposits like this, first you rule out lymphoma. It may be one form of Hodgkin disease. You see here multiple deposits in a known case of primary sarcoma, then you can say it is splenic metastasis. Many number of tumors. On the whole, the splenic is a highly vascular organ. Splenic pulp requires a good amount of blood supply because it frequently and periodically and continuously also refreshes our circulation. As I told you, it removes the worn out cells, all types of worn out cells, including platelets. And so, whenever the blood supply is compromised, then a portion of the spleen will undergo infarction, necrotic changes, and finally it may become an abscess and then heal by fibrosis. So quite common, whenever there is a splenomegaly, huge, massive splenomegaly, when it crosses 18 centimeter. So I told you the normal spleen size is within 12. The medium size small enlargement is below 15. Medium size is 15 to 18 centimeter length. Huge spleen, massive spleen, so-called massive spleen, when it measures above 18 centimeter. So whenever there is massive spleen by measurement, you must be very careful. At any time it may go for infarction. A few examples of massive splenomegaly is sickle cell disease, where you can get a very big, and in these cases, one is it requires massive blood supply also, suiting its size. Number two, in sickle cell disease, already the RBCs are sickle shape. That is why it is called sickle cell disease. So they frequently undergo rouleau formation, precipitating thrombus. So infarction quite common. So you must be very careful in such cases. And other etiology, of course, you can enumerate number of causes. Even trauma can cause splenic infarction. Just now we were talking about wandering spleen. And infections like pancreatitis or pancreatic tumors. So pancreatic disease in general can lead to splenic infarction. Any source of septic emboli, septicemia, can go for splenic infarctions. So all these are the causes of splenic infarction. How does it look like? On CT scan, you can see focal area. When you compare the whole body of the spleen, you can easily pick out these infarcted areas. So when you do the cross section at the particular level, axial CT scan, you can see the wedge-shaped infarcted area. So here the wedge shape is typically demonstrated by the ultrasound. You can see here a triangular with a wide base and a narrow tip pointing towards the hilum. So this is the description of the wedge-shaped infarct. So you have to be careful. Even in fungal infection, splenic infarction can occur. So any disease, you treat then and there, you advise the patient to take full treatment to cure. So even a primary complex patient, a child, if he is not continuing the treatment properly, he can develop secondary tuberculosis at any stage, any time of the age. And when it goes for miliary tuberculosis, this spleen may also be involved. So any disease, you advise him to give good health education and advise them to follow up your advice, your instructions. So you can see huge infarct here. So almost involving half of the spleen with irregular margins. Okay, you can see coronal section of altar. Oh, by the way, I remember in the last cohort, 2 students were not able to identify, to say the view. See, how can you confuse an axial view with the coronal view? No, it is not digestible. When you give such answer in the exam, that means either I failed in my art of teaching or you fail in your intellect to understand my teaching. See, axial view, it is like this, you can understand. You can see the anterior structures and posterior structure in one slice. That is the typical of axial oval shape. Coronal view, you see the longitudinal aspects of the structures. After seeing this, suddenly I remember I want to highlight that point. Don't write this as an axial view or sagittal view. Sagittal view, you can remember just colloquially, something look like a lateral view. So don't confuse the views, because easily you can get 2 marks, 1 mark in OSP. If you write a wrong answer, just a simple mistake, you will be losing 2 marks. You see here, multiple heterogeneous calcified areas. Infarction heals by fibrosis and calcification. Recently, this happens not only in the eastern side, but in western side also it happens. So sometimes they remove the wrong organs. So they remove in one patient complete spleen, surgeon, complete spleen. I don't know in what mood he was, and the patient died. Even though now so many imaging facilities are available which can give you accurate anatomical description and possible diagnosis also, people are doing mistakes. Before finishing, I want to expose what is the sort of lymph node. I would say spleen is a big lymph node in function. Now you can understand what is the importance of lymph nodes. Lymphatics is another important circulation, like blood circulation. But people are not talking much about it. We are always concerned about blood circulation. Lymphatic circulation is very, very important. Occlusion of the lymphatic circulation can be detrimental. One of the, whether you have seen or not, yesterday I have seen in hospital Sundaybulu, a man is not able to move because of not obesity, because of huge thigh and huge lower limbs. This is called elephantiasis. I would say each lower limb would weigh at least some 50 or 60 kilos. See, just occlusion of lymphatic flow by the filarial inconspicuous organism. Why? The lymphatic circulation. So starting from the tip of your great toe, it runs like blood vessels throughout your body. Okay. It shows you that it is suffering